Good afternoon. My name is Eduardo Peñalver. I'm the president of Seattle University, and I'd just like to first start by adding my welcome and thanks to those that you've already received today. We're delighted to have you here on our campus. Thank you for being here for this important discussion about healthcare and technology and ethics. This is the second year of our Tech Ethics Initiative, and we're proud to serve in this role as a convener for thought leaders from the worlds of government and academia and business and civil society to talk about these important issues. And we definitely look forward to next year's installment. So our next session is another panel discussion, and several of the speakers are people that you've already heard from today. And I'm sitting here on the stage by myself, so I guess they're going to come up when I say their names. Stephanie Simmons, Vin Gupta, Alex John London, and Mjaye Mazwi. And then joining them will be someone we haven't heard from yet today, Joanna Black, who is the general counsel of Madrona Ventures Group, which is a Seattle-based venture capital firm with a focus on the tech sector, particularly here in the Pacific Northwest. So, well, why don't we just start with this? And this echoes some of the questions that were presented from the audience. But the question is really about the importance of approaching broadly all of these questions we've been discussing today from within an ethical framework, and kind of considering that the role and the boundaries between self-regulation, law and policy, independent organizations, advocates, and watchdogs. Stephanie, do you want to take a crack at that first?
Hello. Yep. I think that is a big part of what I was talking about earlier in terms of we all have to be part of this work. And self-regulation, it's, I guess, been working okay so far, but that's not, I think that's not the ideal situation. I really liked the comment that Blythe was making earlier about how you're probably going to see a lot of innovation happening in other countries overseas. There's just, that makes perfect sense to me. I can already see that happening with some of the connections that I have. We're going to hold ourselves back a bit if we can't learn how to work together and sort of overcome some of the structural boundaries and things that exist in this system, I think, in the US. I don't know if I had a lot more to add in terms of the frameworks of what I presented earlier, but.
What is the sort of ethical foundation for evaluating the output of these models as it relates to healthcare? Do you have some thoughts on that? One of the questions that, I'll just work this in, because one of the questions that came from the audience was a comment by Alex London about AI predicting costs, patient costs, and that Black patients are likely to be more expensive. And the question is, like, what do you do with that? And what is the role of the entity using AI to respond to that data, that finding, and what is the role of government, as or other entities, as to protect people from the misuse of data like that?
Yeah, there's a lot of issues with that. I mean, we take a human-centered approach, and I think how to think about taking a human-centered approach is just a super important question for us to all be thinking about. It starts with what kind of data you are using, right? And really examining that data and understanding where it came from and whether it's representative, using proxies, as you talked about in the study. That can be a dangerous thing. So, I think just taking the human-centered approach, and that means bringing all the voices. I mean, some of the work that we're doing in my team right now is a research study getting perspectives on the use of AI in clinical trials. And so that is going to include talking to patient advocacy organizations, people that actually work in clinical trials management, also the clinicians and regulatory professionals as well who have to prepare documentation. Where would they be comfortable with using AI to expedite, gain some efficiencies in the process, and where are we going to need to be careful, right? There's a lot of potential use of AI in clinical trials, I would think, even maybe expanding the reach of trials to people in remote areas through digital monitoring, decentralized trials. But I think, hearing the perspective of patients is really important.
Yeah. Alex, I don't know if you want to respond to that question as well, since it was a little bit keyed off your comment earlier. Like, how does an ethical framework allow you to respond, or a regulatory framework to findings like that?
So I think
Go up. Yeah.
Okay, sorry. We're in the very early days in this field, and I would say 3 examples that are all in the same country and all in the same world. So if you Google NVIDIA and nurse, you'll go to a bunch of news articles about NVIDIA announcing that they've got $9 an hour nurse bots, so that when you're, say, discharged from the hospital after cardiac surgery, then you can ask all your questions about follow-up to this nurse bot. It's powered by large language models, so that's example 1. Example 2, McDonald's just shelved its AI ordering in the drive-thru because it just didn't work out. It wasn't cost-effective for them. And then example number 3 is Air Canada put a chatbot on its webpage to help explain its many policies to its users. A gentleman whose mother passed away said, what's your bereavement policy? Can I just, do this? And the chatbot was like, absolutely, go ahead, which was not true. And then later on, Air Canada was like, sorry, that's not our policy. You shouldn't have listened to our chatbot. And when they took, so he took them to court. And in court, Air Canada said, you shouldn't have listened to our chatbot. And by the way, it's responsible for its own self. It's not our thing. And the judge said, yeah, no, it doesn't work that way. And so they were liable for it. All 3 of those things are happening now in this very world. And so it makes me wonder, like, if McDonald's can't get it to work in the drive-thru, how well are these nurse bots really working? And so I think, part of what a regulatory framework does in the pharmaceutical world is it says, here's the objective evidence we need to see before you can sell your product. We don't have any kind of gatekeeping like that, so people can sell their product by telling you that it works. And, if you read the fine print, they're also probably telling you that you bear liability for using their product because you probably shouldn't, or something like that, like Air Canada was trying to say. And so I think we really need a more mature framework that says, here's the evidentiary standards that we think are reasonable before you can sell your product for this kind of use case.
On the clinical side, Vin and Mjaye, what does it mean? Stephanie used the term human-centered to describe a kind of ethical framework. What does that mean in this context in clinical practice?
Yeah, I was actually just thinking about that term because I think in healthcare, at least for me, human-centered actually means patient-centered. And I think we have to be really explicit about that because what might be right for a human that's an administrator of a healthcare system might not be the right thing for the patients in that system. You have to be careful about which sort of marginal you're optimizing for. And I think that actually feeds back to your question about the difference between the role for, say, for instance, federal regulation and self-regulation. I think depending upon what marginal you're optimizing for, self-regulation can be a very dangerous thing. And that's one way of sort of stratifying for which sorts of use cases might be better examples of places where you can safely self-regulate when compared to others.
Well, especially when you think about, that last point's so important, when you think about the background framework governing the obligations of the managers of publicly traded companies, right? They have very specific directions about the margins they're supposed to maximize, and it's not the patient necessarily.
That's right. I mean, if it generates a tremendous amount more revenue for your healthcare system to wait until patients are very sick and then provide them with heroic care when they are in many cases beyond being able to be salvaged with meaningful outcomes, then that's obviously not a patient-centered innovation, and certainly not the kind of innovation we want to see optimized for.
Yeah. Vin, do you have anything?
Yeah, I love those insights. I mean, I would say that I just think where I was having a conversation just during the break. That was why I was late. But it was the emphasis was on we don't have enough of the patient perspective in a lot of these discussions, which I think is correct. And the upside, I think that there is just so much that's wrong with access right now, or patient awareness of services that they might benefit from because their employer has contracted with certain healthcare vendors to give them access to mental health services, or you name it. So much goes unutilized, Eduardo, that people actually have access to for free that could help with early prevention of disease, or to keep something that might be in an early stage at an early stage. And so patient awareness, access to health, Amazon, for example, we have, our hope here is that maybe through navigation of our healthcare services online, somebody will will understand what might be happening to them earlier in the course of, say, an infectious disease and get treatment more quickly. The concern there, of course, is that we're at a time when the most trusted provider of healthcare information, and this is something that Edelman, actually, the national pollster firm, had released at Aspen, is now again the healthcare provider, the physical human healthcare provider. And so I think the aspirational view here is that an AI-empowered chatbot for healthcare helps with access in a world, Eduardo, where 1 in 2 people don't have access to same-day or next-day care if they're acutely ill with COVID or flu. I think that's noble. And I hope, as a lung doc, that does the trick of making sure that patient gets access to care quickly. Do I think it's human-centered? Not particularly, but it's solving a problem that's noble and important. But it's also doing so at a time when the most trusted provider of healthcare information is the human provider. And so if we talk about trust, will people trust that AI chatbot in the first place? I think that's the tension.
Joanna, do you want to just speak about this from the standpoint of early stage investment? Like, when you think about some of these AI tools, the stakes in the McDonald's drive-through are low, I suppose, but in the healthcare context, quite high. How does that push you? Like, if you're thinking about the kinds of companies and risks of liability over the medium and long term in choosing among AI startups?
Yeah. No, I think that's a great question. So I do think that the early stage AI companies are in a very different position than, say, the Microsofts of the world or the Amazons of the world. And I think it's important to remember that the world that I inhabit, to clarify, I am not an investor, I'm not actual VC. I am the general counsel, so the lawyer at the VC, which is sort of, an interesting place to be, and a kind of a subset of what we're all talking about, which is I sometimes act as the brakes in a world that's moving quite quickly. And in order to be effective on my job, I think that, it is an example of what we're all talking about on the meta level, which is that when they're looking at these early stage companies, and Madrona invests in pre-seed, seed, Series A primarily, these are founders who have an idea, they might have some viable kind of product, minimal viable product. There's not a lot there, and there's a lot that can still go wrong, as you know, between when we put in our first check and years down the line, if it's going to be successful. Are they going to scale? Is this actually going to work? And so you can't be, I think it's hard to expect investors at that stage to put the brakes on too quickly. You almost have to have this, I call it, irrationally optimistic view. It's sort of the job of the VC at this stage. And so I'm not saying we shouldn't evaluate ethics. We talk about it. We actually get involved in groups where we're helping to educate the government, or we work with the bigger companies like Microsoft and Amazon, and we work with lobbyists. We work with a lot of people to sort of understand, but from our standpoint, we're all about the fuel. We're all about let's move fast, because we need innovation to happen. And if there isn't someone doing some of that, then, it's a balance, and we're not getting that balance.
I'm glad you described yourself as the brakes, because as a fellow lawyer, I didn't want to go there, but I know lawyers don't like to describe ourselves that way all the time, but it's
a very important job.
It is an important job. So maybe stepping back a bit to more first principles in thinking about regulatory frameworks or self-regulation or the role of ethics. What should the starting point be? The drug I think, Alex, you brought this up, the sort of drug regulatory framework very much starts from a kind of precautionary principle. You're not allowed to market something as a drug unless you've demonstrated its safety and efficacy. In other contexts, we have a sort of green light until you find that something's dangerous, and then regulation steps in actively to stop it. My sense is the Europeans generally start with a more precautionary approach. Americans a more kind of libertarian approach. But you want to comment on that dichotomy, or where should we start in thinking about AI with a more an obligation to prove safety before something's put into practice, or maybe it's and I'm really focused here on the healthcare context, right? Not generally. You want to start there? You can kind of, whoever wants to jump in on this, but Joanna.
Well, I do think that healthcare is a very particular kind of field where you have to be extra careful. Obviously, this is why we have clinical trials, and we have IRBs, and we have FDA. And so I think you have to take that aside. As a general overarching philosophy, I think it is important for us to take a step back and just remember that it doesn't, I think, benefit society to focus too much on fear all the time. So I think you have to have a balance. You have to have enough fear. You have to have enough hope. You have to, allow sort of moving fast, moving slow. You have to take 2 steps forward, 1 step back. And this is a very frustrating process for people. There are certain people who prefer to be on the let's move fast bandwagon, and others who are like, oh my gosh, let's hold on and be slow. And this is sort of the beauty of our society. I was reminded the other day of the fact that in the 1860s, I'm not a historian, but I'll try my best here. There was a moment where suddenly there was a proliferation of newspapers, news articles, news groups. Sort of everyone had their own slice of, I don't know what they called them back then, but it was suddenly very prolific. People were inundated. Farmers who previously didn't have any access to information suddenly got all this information. There was all this misinformation, and people were, from different, and it sounded so familiar to what we're experiencing now with social media and with AI. We sort of, as a society, we've been through these exercises, and this is sort of advanced level for sure. But I do think it's important to sometimes remember that, you have to step back. If you're looking too closely, you have to step back. If you're looking too far away, you have to step close.
Can I add on to that?
Please.
I love that point. I thought it was beautifully said. In healthcare, I think the big paradox is that 70% of people are on a supplement that is not regulated by the FDA. It's the Wild West to some degree. It's patient empowered. It's the definition of patient empowerment. They do what they want, and they source their own information. And some would say it's arguably unsafe. 60% are on a prescription medication, highly regulated space. And now we're talking about longevity. Do you get the Pernuva scan? Do you not? All these things that are patient-driven with minimal input in some cases from a provider. And so I would argue that we're way too in our heads when we think about regulation. Is this safe? Is this not safe? Because people are generally, when they think about putting something in their mouth or get a scan, they're maybe in this new age doing it without the input of an allopathic or homeopathic provider. So that's one. And then two, some of the most interesting, the leading killer of humanity is hypertension. It's been the case over the last many decades. Some of the greatest innovation, and one of the reasons why is our screening tools are the blood pressure cuff that 1 in 10 people utilize who have blood pressure. The other 90% don't because they don't like the actual screening experience, which is a reality. And so if we're talking about better screening tools, what are they doing in places like Switzerland and Israel and South Korea? They're building AI-enabled platforms that allow for contactless biometric scans that work about 85 to 90% of the time. You go to the FDA with that, and Bob Califf, a cardiologist, the current commissioner, he said, hey, that doesn't meet our bar. But if you really think about smart risk and pushing the envelope, I'd say, why wouldn't we do that with the right guardrails and patient education? 85 people in 100 will know they have hypertension. The other 15, maybe we're sending to the PCP and annoying the PCP because they don't need the check. But I'd rather that than in the next 30 years, hypertension continuing to be something that we diagnose too late. So I think we're too pedantic on something that, frankly, we shouldn't be.
This really is like an ethics class, by the way. It's like the trolley problem or something.
Yeah.
No, I couldn't agree more with that. I think, it's interesting because one of the points that you're making that I wanted to underline again, because I think it's a fundamental point here, is we have to understand what challenges are unique to AI and what are more general challenges that AI magnifies. An example being, we've been talking a great deal about bias. I feel like sometimes when we have these discussions, there's almost the sense that the models that are generated using AI are biased in some horrible and new way. The truth of the matter is that if we're using the same historical data in our traditional statistics in medicine that have driven a lot of our insights to date, we are subject to all the same biases. And so I don't know, to answer your question directly, I don't know exactly where that cut point is, but I do think that sometimes the opportunity to utilize a new technique to push harder on these problems allows you to have a more proactive posture to trying to address the actual underlying rate-limiting steps that we haven't seemed to get at before. Then also a point that Vin makes that I want to emphasize, and it's a distressing thing to say from within healthcare, is that the room for improvement is massive. And I think we have to be careful about what we're actually protecting ourselves against. I think that the potential for marginal gains is huge. And we have to be careful that we're not putting in place a regulatory regime that doesn't allow that to happen.
Alex, you wanted to
Well,
jump
so
in.
I think I'm a big fan of decentralized innovation and letting people experiment, because it's very hard to centrally plan what's going to work and what's not, and that's best found out in the world in most cases. I think healthcare is slightly different, because if you move fast and break things in healthcare, the things you're breaking are people. And we'd rather not do that. And so I worry about this idea of so I think a real important question here is, what's the relevant baseline? There's a large literature in the test, about developing a test for something. One of the previous speakers mentioned diabetic retinopathy. Huge, very well worked out, great example of a long-term process to develop systems to diagnose more than mild diabetic retinopathy that went through prospective clinical trials, and that's why they'll be reimbursed, and it's gold standard for how to do some of this stuff. Now, but that was all within a high-risk population, and if you decided, let's put this in your local grocery store, our local grocery store is called Giant Eagle. If you just put it in the Giant Eagle, and anybody can sit down and have this thing diagnose them, you're gonna have a huge bunch of false positives, because you got an incredibly low risk population that's gonna sit in that chair. And so this is what I worry about with your Apple Watch, your Fitbit, and all this other stuff, where it's we have a healthcare system that is already overburdened. The people who need to be seen have trouble getting seen. And if people are showing up because they're my watch told me I have AFib, and you're I don't want you here, you're fine. That's a real consideration. And so I feel when consumer products move over into healthcare, then this discussion about what's your false positive rate, what's your false negative rate, how do you ensure that this is only used in an indicated population? And I worry about the file drawer effect, when it's Apple gets out in the news, this person was saved by their Apple Watch. And I'm great, how many false positives were there? What, we don't see the full denominator. And so in the clinical medicine, we make you show us everything, show us all the denominator. But when commercial companies are I can cherry pick and show you my best case, it's what's under the ocean? What was underneath that? And how many people went to their doctor and were hey, I have this thing that I don't, and that had to be walked back.
Stephanie, did you want to weigh in on this?
Sure. I love this conversation about the appropriate risk threshold in the healthcare setting, and where have you made the situation better, and just where is all the low-hanging fruit? We take at Microsoft, as I said, risk-based approach, and so that means that there may be types of models and services that we won't release, or we'll only release to a limited set of customers that kind of have to register and prove a use case. The analysis is very use case specific that we do with responsible AI. So I think that's just seems in healthcare, one of the most important conversations that we should be having is just taking another look at how we think about risk, and probably reimagining a lot of the current health regulatory infrastructure, if that is really just getting in the way, right, of practical solutions. So I just love these perspectives, I just hope they're making their way to the FDA. I assume, like the government, I know they're doing a lot of work in this area, and things are moving very fast. I heard our new CVP at Microsoft of AI, Mustafa Suleiman, was speaking, I think, yesterday. They were asking him if you were using baseball metaphor, what inning are we in? And he was saying, in terms of generative AI and the potential of AI, we're in the very beginning, right? So, the opportunity in healthcare is obviously tremendous. So hopefully we can keep pushing a little bit on how we think about risk and benefiting people.
Can I just weigh in something just to build on Stephanie and Alex's point? I think Alex's point is important because that's how we've been thinking about risk for the last several decades of innovation. We want to minimize the false positive because we don't want to overburden the system with people who do not need to be seen. And I would say, as an intensivist up at Virginia Mason, we need to start challenging that paradigm because you know what's happening? The ICU is getting filled with people with heart attacks and strokes. Oh, by the way, those are the leading killers of death in the United States and elsewhere. So what are we willing to tolerate? ICUs overfilled with people with end-stage disease because they don't have the tools to know that they have earlier stage disease. They're not utilizing it. Poor patient engagement is the big issue of our time. We don't like to talk about it. The diagnostics don't meet the moment. They don't like to use the Omron blood pressure cuff. We can debate why, that's a different discussion. But either we're willing to tolerate or not willing to tolerate some false positive, which I agree is a problem we have to manage, or we're gonna have the continued global burden of disease for the next 30 years, which is ICUs filled with preventable chronic disease that ultimately goes to end stage. I think we need to start having hard discussions about what we're willing to tolerate in the healthcare system.
So this, the pace of change question is an interesting one, and there really, you think of multiple dimensions to this. One is the pace of change in terms of the capabilities of the large language models, and I'm not a technologist. My read on that is that there's a debate about this, right? There's certainly been a high pace of change in the capability of those models over the last few years. Whether that we can project that into the future, or whether they're going to be diminishing returns. This discussion about running out of data to train new models. Scale is everything, but we've reached maximum scale, and so now we're using synthetic data. So one is the pace of change in terms of the capability of the models, but then the other is the sort of pace of change in terms of uses of even existing capabilities, right? And both of those maybe independently present challenges to this question of risk management and self-regulation. What do you see as the impact of that pace, right? As it feels unsustainable just in terms of our ability to grapple with the state of the art at any given moment. How do we then manage it? And what are the tools that technology itself can help bring to bear on that challenge? Stephanie, why don't you start on that?
I was just thinking about it. I do think, so in terms of the technology, I work in Microsoft Research, and I just see a lot of people just really excited about digging into different opportunities with multimodal models. Small language models are kind of the latest thing now, the Phi 3 model that's been released. And yeah, the challenge of, getting good quality data. I doubt we're going to run out of data, but I think also some of the machine learning scientists are discovering that you can do a lot more with less data if it's the right kind of data. So I have a lot of faith in the technologists to help us solve some of these problems. Yeah, I don't think that answer your question.
Well, the question is just, how do we keep up as human beings? We don't change that quickly.
Right.
So just assuming, let's take the tech optimist case, that this is going to keep going in a kind of linear way. That seems intimidating. How do we manage that pace of change?
There's a philosophical conversation. I forget the name of the philosopher at NYU. I was just listening to something about
Gary
this.
Marcus? No, he's a psychologist.
Anyway, his name, I think it starts with a C. I'm so sorry, I don't remember because I wasn't trying to remember that for this talk, but kind of just as technology as an extension of us. Yes.
David Chalmers.
Yes, thank you. Yeah, I mean, I kind of think that way myself, so I don't know if that would, that maybe, I don't know, maybe that's just me. I am a technophile, obviously, like I've been working in technology my whole life, and so yeah, I use my family members as my hard drive sometimes. I'm looking forward to having my personal assistant robot fairly soon, I hope.
I'm still waiting for my flying
That would be an
car.
extension of me. And I've been dreaming about this for a decade, and I didn't believe that it would come true while I'm still like relatively young. I thought it would be maybe something I could get in like the old person's rest home, but yeah, so I think we just have to use the technology to like help us process this stuff so that we are using our abilities to what we're good at, and just being human, whatever that means these days, right? We have to think, I think our prior speaker, Christof, was talking about that, we're not just, what is consciousness, right? We're not just objects that do things, right? Because the computers can do that better than us, probably in a lot of ways. So anyway, I'm kind of rambling a little bit, but I think technology is the answer to how do we consume this information more effectively.
Alex, you're chomping at the bit here.
I think this comes up a lot when it's how does regulation keep up with the pace of technology? And I think that's a legitimate question, but I think there's a prior question. How does a health system implement a technology if it's obsolete 2 weeks from now, 3 weeks from now, 6 months from now, something like that? To me, that's a more fundamental question. How do you, so I think the healthcare and the military are these two places where it's nothing's at the cutting edge because you need to validate it, you need it to work, it's got to work, in lots of different conditions. And so I think there's just a fundamental clash in cultures, and there's a real desire on the part of the tech companies to make healthcare more like the rest of the tech world. And I think there's just the friction there is people, and that you have to deliver healthcare to people in healthcare systems that are run by people. And it's just not going to be feasible to be yep, every 6 months we're retooling and re-implementing and retraining on another system. So the fundamental challenge is going to be, how do you get to a place where you've got enough innovation in an area that you can create a tool that then you can sustain and augment and build on and make sure that you're ratcheting forward and not just moving the pieces around and consuming more money without moving the ball down the field.
Yeah, thanks for taking us there. I just went to the doctor yesterday and signed 3 pieces of paper. So the slowness of integrating new technology is really striking in the medical field. Mjaye, do you want to weigh in on this?
I think there's a difference between fully understanding a technology and making sure that you derive benefit from it. My grandmother can navigate across town using a GPS system. I would be surprised if she could explain how that system works, but she derives benefit from it. And I think that we need to understand that both of those really important ways of leveraging technology exist. In all epochs of human technological innovation, the number of people who fully understand technology and its implications has always been much smaller than the number of people who derive benefit. And that's going to be true of this as well. I forgot my second.
Well, yeah, what do you, Alex's point about just how do you implement these technologies within a medical system given the pace of change within medicine? Yeah,
that's medicine is an inherently conservative field, and Alex, has made this point. I think these are some of the fundamental things that do need to change. And something that we haven't talked about yet as a barrier that is a barrier is legacy technologies in medicine. We have such tremendous investments in the technologies that we use in providing care that we often are unwilling to move beyond them. It's sort of the sunk costs idea. And that means that most hospitals from a technology standpoint are these incredibly unwieldy and ungainly amalgams of things that don't work well together. Very few of our systems are networked and are able to compensate for failures in other aspects of the system. And so I think what we're talking about is how, in order to be ready for this kind of innovation, we need to evolve our technical infrastructures in hospitals. I did actually remember what the other point I was going to make is that
for it.
I don't perceive that we have a problem in healthcare with inadequate data. I think we still have a fundamental problem with data access. And one of the many things that is going to have to change is concepts of privacy. As an example, with a show of hands, if any one of you in the crowd here was marooned in an ICU or a hospital and the treating team, the team of clinicians taking care of you was stymied, didn't understand what was wrong with you. And you could democratize access to your data, make it available to a much larger group of people to weigh in on in a way that might help you. Would you do that? Yeah. Yeah, and I think that this is an important observation because as these techniques advance in their capabilities, this is the question we're going to have to begin to confront. To what extent is the way that we think of data privacy actually hindering the kinds of outcomes we want to secure for our patients rather than helping?
And this is my last question before we bring everyone else up and go to the audience questions. I'll make this as broad as possible. How can universities, and I'll include medical schools in this, prepare students to grapple with all these questions we've been talking about in a more sophisticated way?
I'll go. I think discussions like this obviously really help awareness. It's like the old adage of the fish that's swimming through the water and it runs across another fish who says, "Hey, how's the water?" And he swims away and the fish looks at his fellow fish and says, "What's water?" And I think it's one of those things where, we're sort of constantly having to deal with ethical dilemmas and we have to make hard decisions and we have to adapt to changes. And I think having real lessons and intentional education on how to think bigger picture, how to think about the water that we swim in that can be easily ignored, will go a long ways to helping society as a whole take advantage of the innovation and technology as it moves quickly, while allowing it to have a net impact, positive impact on our society without being too scared of what's going to happen, because we've had the training to have these hard conversations, have these debates, have the people in the room who want to push forward and have the people in the room who are more cautious sort of help figure out what the best solution is.
So this will be red meat for you. I think the solution, part of the solution, is we need a broad liberal arts education for our tech people, because I think having a very narrow, this goes from I see pre-med students who've only ever done science, and so the humanistic part of the fact that you're going to die. There's this genre of novels of doctors who write books that are like, "Oh my God, I realized I too was going to die." And it's like, what were you doing in residency in the rest of your life? So I think giving people a sense of, what it's like to have a life, the diversity of experiences, but also why is our government arranged the way that it is? What is checks and balances? What's the difference between there's a lot of I don't know what you call it, romance out there for sort of totalitarian organizations. A king would do very well these days, right? Look, we don't have to deal with all these democratic divisions and stuff like that. It's history would be very valuable so that we don't reinvent some of those wheels as well. And I think that combining, at least enough where you can speak to the other people, all of these problems, AI is always multidisciplinary. And so having the people with enough awareness that they can speak to people in other disciplines is absolutely key.
That is red meat at a Jesuit university. Yeah, thank you. I'm looking at the academic leadership here. They're all nodding. We don't graduate technologists who haven't had humanities in their curriculum. So, Vin, did you have anything on, what about medical education? I mean, in particular, what do you see as the obstacles to producing doctors who are more sophisticated in this area?
Well, there was a study that I'm sure many of you have seen or are familiar with that AI-enabled communication that was transcribed from a generative AI platform in response to a patient query was more empathic sounding than what the human doc did as their counterpart. Sort of, as randomized of a control trial as possible to look at the efficacy of AI when it comes to at least patient-provider interactions. Medical schools and just universities in general, Seattle University, needs to be part, and I know will be a part of this scholarship, because we need to know, I mean, it goes back to the problem solution paradigm. What's the problems that we're solving for? You know, I know there's some AI chatbot efforts to encourage people to do advanced directives. And some of you may think that's perfunctory and a little ridiculous, but I look at that and say, gosh, 30% of American adults actually have advanced directives on file. The other 70%, when they hop into the ICU unexpectedly, we have no idea what their goals of care are. In some cases, we have to assume. And in the last 3 weeks of life, that's where 40% of healthcare costs accrue. And so if you're telling me, hey, let's see what an AI-assisted chatbot for advanced directive acquisition, does that actually move the needle or not? I'd love to trial that and see if that's actually moving the needle. What about AI-assisted chatbots that we're launching through Amazon? Is that doing anything for early test and treat for infectious diseases, or is it useless? I think that type of knowledge acquisition is important, so then we can train the next generation of medical providers to say, it's good in these use cases, it's less effective here.
Great. Well, I'll invite at this point the previous panelists up onto the stage here. And as we're waiting for them.
I was actually going to add one thing to that, which is this might be a controversial perspective, but I actually think that in some ways medical trainees might be better prepared than they think. You know, if the framing is that, you know, getting to a point I think that Blythe was making about how you know, clinicians that are utilizing these techniques are going to replace clinicians that aren't. What we're actually going to be trying to teach these folks how to do is be effective collaborators. And you know, a lot of the more complex forms of medical care are already very collaborative. We consult each other. Becoming an effective collaborator in that paradigm involves not just understanding how an evaluation is made, but understanding when that's in a recommendation you might adopt and when it isn't. And there's some narrow technical domains, but there are obviously also some philosophical domains. And so I think it might be less of a heavy lift than we think.
So I have questions from the audience that were shared with me, and if there are more that Emily wants to bring up, I can grab them on the fly. But we'll have to share microphones because we don't have enough ports for everyone on the stage. But all these are for anyone to jump in, but I have one that was specifically directed to Christof. And so I'll start with this one, but then anyone else wants to weigh in on this as well. The question is, we're stuck now, Christof, you said we're stuck now with AI, we have to learn how to use it. What does that mean, and do we need to learn to use a tool regardless of how useful it is?
Yeah, because we only know that it's a tool to the extent that we use it. I mean, you know, if we don't use it, it's not a tool. So we have to use it, and we have to discover the benefits, and we have to discover the many perils it has. And so there's always this risk-benefit trade-off. The first part of this comment is that as a biologist, we are the dominant species on the planet, not because we're the wisest, but because we're the most aggressive and the most intelligent. So now we are developing species, you know, a new type of organism that's not evolved but engineered, that's going to be more and more intelligent. And of course, inevitable, you see this already, the evolution of swarms in Ukraine and Russia. They're going to be dedicated to what all of our tools are dedicated for, which is warfare, right? This is going to happen, whether we like it or not. Is that in humanity's long-term interest? I'm not sure. But, you know, here we are. We can't uninvent it, so we have to deal with it. That's my position.
Anyone else want to jump in on that one? Okay. What about we haven't talked about, I mean, and this maybe goes beyond the healthcare context, but the environmental impacts of AI, you know, both in terms of the production of AI and the vast amounts of energy consumed in training these models. But also, you know, perhaps, you know, the example you just used, the environmental impacts of the utilization of this technology. How do we think about that?
think if you look at any models that you see on the news, they talk about only this billion parameters or a million parameters or anything like that, right? So typically a billion parameter model, if you want to do a one set of training, it costs you $1 million roughly. You know what I mean? If you want to train to take it to end. So I think there is a power, there's the all consumption and everything that goes with it. But one thing I can tell you, in the last 2 years, the cost of this has been coming down significantly. There has been so much progress. It is actually faster than Moore's law. It is coming down very significantly. And also the second thing is, you guys must have seen that in the news, that it's not about the big models. You know what I mean? It is compound AI systems are coming together, which is called agentic frameworks. And the agentic frameworks, you can have small models actually can collaborate much better. So, which means you could achieve, so you will have these small agents that can do a specific task at much high precision or accuracy than a bigger model. So when you use the paradigms like this, I think the things are going to come down. But however, we always need to see, what do these systems replace? There are other systems which were taking these workloads before, and this is replacing the other systems. So in a way, if you look at, we are in a new innovation curve. There's a new innovation curve, that has picked up, and people will catch on to that new innovation curve. And there are certain things that are under, I'm talking about the innovator dilemma curves, where, the rate of innovation keeps coming, and you need to catch to the next innovation curve, and other things that below it are going to go away, because this next one is going to be done at a lower cost and is going to address it much deeper knowledge than it has done below. So that's kind of my quick answer.
One observation, I don't have an answer to this, but I was just thinking about this curve that he's talking about, that this actually particular innovation is going to affect disproportionately white-collar workers versus blue-collar workers, which is a kind of a new thing for us. And that's going to be an interesting thing for society to adapt to. And maybe it's uniquely easier to try to learn to adapt to it, but AI is going to first start to replace, relatively educated workers. That was just a thought that came to me. I have no follow-up to it, but just thought I'd throw it out there.
I think it is a social challenge for our society to figure out how we're going to solve coordination problems that involve the use of shared and finite scarce resources like carbon. So we're warming our planet at an unsustainable rate. The health consequences of that are going to dwarf anything that healthcare is going to be able to address. And at the same time, we're burning huge amounts of carbon so that people can, with a prompt, create an image for laughs. And so there's something deeply tragic about that, I think. And I think our failure to be able to address the climate crisis is a failure in our ability to think collectively about which sorts of things we want to sort of. So there's one thing to do research and understand things, and there's another thing to commercialize a product and send it out on large scale. And so right now, in a sort of decentralized environment where people can make those decisions, they can burn carbon and they can reap the benefits. It's the tragedy of the commons. It's exactly what it is. And so, Dale Jamieson has a book about how we failed at the climate crisis, sort of in the past. I don't want to be really more down than I already have been in this comment. But I think that those sorts of things are really fundamental challenges.
How do we ensure the ability of democratic actors to be decision makers about AI?
It would help if some of them talked about it. How often have you heard our president or the other guy talk about any of this, remotely about any of this?
You do have someone on stage who's had to explain math models to Donald Trump in the Oval Office, so I can say it's difficult.
I actually worry about this one a lot because I think that the incentives for non-democratic actors to leverage these technologies are always going to be larger than the incentives for democratic operators. And beyond advocating that people vote in better people and move away from authoritarianism, I don't know what the solution to that problem is.
This is a really interesting question that someone in the audience asked, and now that everyone's on the stage, it's a sort of apt question, but who are the voices that we should be hearing from that we are not hearing from? So, like, who did we fail to include in this? Not individuals, but sort of groups.
Patients?
Yeah, that came up earlier.
Those are the ones we're talking about after all, right?
I'll echo that too, because we've talked about a range of use cases today, from drug discovery with identifying proteins to clinical decision support that will help the provider make a decision, to payers and getting access to reimbursement. But I think Vin actually had mentioned just a little bit earlier the patient engagement component. And it can be really difficult from a patient perspective, but this is why maybe next year we can have if next year your policy.
It is policy.
Yeah. Civilians who policy affects come on stage and just, I think that patient education of complex medical diagnoses and conversations and reporting of symptoms, all these conversations, is something that LLMs are actually really good at. We've talked about what are the most valuable or the least valuable applications, but we also should talk about what are LLMs bad at and what are they really good at. They're really great at summarizing complex information and distilling it into layperson language. So maybe we don't have the best business models yet to think of which tools are the ways to deploy that in a way that really improves patient experience and adherence and outcomes and a patient's own decision-making about what they want for themselves and their quality of life. But those conversations are something LLMs can be excellent at.
In the recent deliberation that I'm sure most of you have heard about of the FDA Advisory Council for MDMA-assisted psychotherapy, right, which 10 out of 11 academic advisors voted against. They felt the risk did not outweigh the benefit. There wasn't a single patient that was actually listened to. So here we have one of the most promising treatments of a new type of drug together with psychotherapy that 10 out of 11 people thought wasn't worth the risk. Without listening to patient, I find this somewhat shocking.
So who is speaking for patients? Like, who would we have invited if we had the intention to make sure patient voices were heard in this conversation today? Who would we go to?
I would say it's a bit difficult sort of advocating in very general terms. It would have to be, if you're looking at a specific category.
Depending on the disease.
Like PTSD in this case, or whatever the case may be, yes.
I think PTSD is actually a great example. I've worked with the Department of Defense and the way that they're thinking about investments in AI for their strategy. And the discussions we've had are, if you think of the number of American war veterans that have returned with PTSD, there are not enough counselors in the United States to care for the number of veterans who have PTSD in our country. And so as we think through risk benefits of using AI tools to engage patients, we can't always use is this as good as a real life counselor in person? But is this better than what they currently have access to, which may be nothing. And so for things like suicide prevention and these other things, I think we have to think very carefully and about the ethics of how to fill unmet need for important populations that are experiencing burden and that there could very easily, not easily, but there could be meaningful tools powered by AI to support and fill gaps.
There's only one thing. When you said patients, aren't we all patients? I was talking to one individual at the break where she was giving her experience about, the cancer detection and the kind of process that she was very involved in the literature and everything. So in the end, I feel that in this whole cycle that earlier I was talking about, patient is a common element. You know what I mean? That's where everything starts, and that's what we are actually helping in the end, saving the lives or saving the So I think we are all there, but the thing is that the modes in which that we need to interact with patients would be different based on what the model is trying to address. And
Any others? We've talked a lot about patients. Are there other voices that we should be hearing from on these issues? On the kind of broad architectural questions as opposed to specific.
one thing I was thinking about is, I don't know the whole audience, but do we have somebody from regulatory agencies or, who work with these kind of approvals and
Often, one category of individual that I was thinking about is healthcare administrators. One of the anyone who does this kind of work within a hospital system knows that it's often a barrier on the subject of different incentives and understanding how that group thinks about either their obligation to support these kinds of initiatives and their responsibility to limit the potential for harm associated with these kinds of initiatives would be an interesting perspective.
So there are a whole series of questions, different versions of questions about bias in the data that's feeding into models, bias coming out of the models. Sometimes those two things are connected, sometimes not. And we've seen examples of, just in the last year of companies trying to kind of provide guardrails on the technology to cut off bias, and that leads to sometimes strange results like the photos of Nazis that were of all colors that came out of the Google image generator. How do we think about those, the challenge of bias in these models, the challenge of bias in the data, the challenge of bias in their outputs, and then the trade-off between the effectiveness of the technology and efforts to curb bias? Should bias be considered outside of the technology, or should it be forced into the design of the technology?
So as somebody who's written about the bias and how we ought to think about it, I actually think it gets too much attention in the following way. Every way a system could go wrong gets labeled as a bias of some sort, and so the term becomes it means so many things that it ultimately becomes kind of useless. And so I think we would be better served by having a broader taxonomy of the types of things that we want to avoid and move away from just talking about bias. Because there are going to be as many ways of talking about bias as there are going to be measures that you can apply to a system. And so in that sense, there's an infinite set of ways that a system can be biased. It doesn't just come from the data. You can have a computation that makes a system biased. It can only be utilized by certain sorts of people, so there can be a bias in that regard. And I think calling it a bias then doesn't do much. Let's talk about who gets access to it. How fair are the distribution across subgroups of how accurate or how effective the system is. And I think then that would let us make sure that we have all these distinct things get their distinct attention rather than trying to see them all as an example of some underlying thing. The other thing being, sometimes if a system is biased, it's totally fine as long as you know it. Like if I have a thermometer that's always 2 degrees high, that's great because I can just subtract 2 degrees and still use it, right? So knowing the bias allows you to correct for it. So, and your system is going to have, an ethical system is going to have to be biased. What do I mean by that? The statistical distribution in the population we have now reflects systematic racism and other problems. If your system is statistically unbiased, it will also reflect those problems. So relative to the past, it's got to be biased. It's got to be statistically biased, because to have a more equitable system, it's going to have to overweight some groups and do other things. And so in that sense, I think bias, let's move beyond bias and let's talk about, like, the very specific things that we care about.
Anyone else want to jump in?
Heterodox opinion.
I was just going to, I think that was an excellent point, and was going to say that this is another example of one of those scenarios where one of my questions is, what is the alternative? I can't identify many ways in our current practice that we are longitudinally trying to accurately measure and mitigate biases. And so this might be an example of a scenario where, in the absence of a great viable alternative, at least the ability to quantify and try to mitigate these biases longitudinally is better than what we're doing now.
Mm-hmm. Well, in a lot of the legal discussions of this, that we distinguish between bias in the sort of process versus bias in outcomes. And one of the critiques of, and this predates large language models, but it seems to be especially true of some of these tools that have emerged in the last year. A lot of the critiques of algorithmic problem solving is that the bias in process gets sort of subsumed within a black box that's very hard to diagnose. Scientists can't explain how large language models work. How can they police the operation of the language model for, let's say, discrimination, right? So then that pushes us to look at the outputs. Is that a fair assessment?
I think that's a really good point. Actually, all the points here have been super insightful. One of the things that I was going to mention was that bias is essentially a blind spot for a lot of people. Like, my idea of bias is going to be different from other folks on this stage's definition of bias. And so often it's a little messy, because you almost have to play it out and have people call it out and say, hey, look, you don't see that blind spot. And I think as a society, we don't always love that. We don't like sort of realizing we have blind spots, but we all have them. And so, and the other point I was going to make is, I can't remember if it was Alex who made this point, but the idea of what we think bias is, which is that your system might have to actually be biased in order to be what we think is unbiased. And it sort of reminded me of when I think it was Apple created, on their Apple Music or whoever, where they have this shuffle function. And they realized that when they did an actual shuffle, which was just random, it would sometimes not be what people thought is random, because they would repeat certain songs again. People were like, that's not random, and actually that is random. So they had to make random what people thought was random, but it is in fact not random. It's in fact, you institute a rule that it will never repeat a song within a certain amount of time, even though randomly you would actually get repeats. And so I always think of that humans are sort of, lovingly flawed that way, and not realizing that they have these blind spots. And I think staying humble and realizing that, hey, you got to work it out. You're doing your best, but then you got to let people sort of iterate on that.
Yeah, the one thing I will add, I totally agree with on your name, but I totally agree with what you said. Anytime when we talk about any model, the first question that comes is, how do you detect bias? There's a bias in the system. But however, there is something that, we at our company, we use this term called explainability. You know what I mean? For example, if any decision is made, the model needs to come up with an explanation of how it made the decision. And sometimes, if you look at the prior, the machine learning models and everything, if you want a proper explainability, you have another model actually is looking for explaining the outcome of a particular model. In LLMs, like what somebody said, it's very hard to actually see how the decision it arrived at. But the same LLM can be used as a critique agent to detect and actually, interrogate if there is bias or where are the areas where it's not working. It's very intriguing, actually, that some of the experiments that we're doing is you could use your critique agent to be able to create a good explanation of how well your other model is working. So,
but that's like what most of us do. We come to a decision and then we look for reasons for why I came to that decision. We want to do it the other way around. I want to have some ethical principle, decide on the basis of that, rather than making a decision and saying, oh, I think it was this reason.
so the thing is that the point I was making is, if humans were testing it versus the ubiquitous knowledge that is baked in the model itself is testing it. You know what I mean? So that the whole knowledge is at your disposal when you're creating a critique agent to be able to test the model. That's the point.
But I mean, if I get turned down in my loan because I live in a zip code that's associated with high default, I don't want to be told, well, it has something to do with your profession and with your education, right? Because that sounds better and is maybe legally acceptable.
Yeah, this did happen, you know, in most of the financial industries. Yeah.
Vin, you look at your...
Yeah, no, I was just gonna, I think this point's been made a few times, but the way we get information, let's take it back to university students and pre-med students. The way they get information now is inherently biased. It's, the teacher says, hey, we're gonna go to Netter, or we're gonna pick this pre-selected reading or resources. They're gonna be specific books. They're gonna go to specific websites, and they're gonna curate their own selection of information that is inherently biased. And so when I think about the ways in which Google now is summarizing information based on a search query, it is at least multimodal. It's taking into account a broader swath of inputs than what I think that individual 4 weeks ago doing that same search query would otherwise have exposure to. One website, read this. And so it depends on, again, how we define what bias is, but information, the way the predicate right now, the way we've sourced information for education, for medical purposes, is inherently biased. We curate the information we want from the resources that we like. And I do think AI has a way of democratizing, or actually building multimodal data inputs and summarizing information from resources we otherwise wouldn't be exposed to.
So this comes back to the point you made earlier, the comment you made earlier about the most trusted, I think this was you, right? The most trusted person is the healthcare provider, the human, or the Alex. But are we less tolerant of certain outputs because they come from a machine than we would be if they come from a person? Is our concern with bias or our preoccupation with bias in this context a bias?
I suspect that we are overestimating people's willingness to receive healthcare information from a chatbot. I think there's going to be annoyance. There's going to be the desire to press 0 to speak to a live customer service agent, or in this case, a doc. But we don't know that. And so the problem this is solving is a problem that there aren't enough human beings to solve for. So I think, and Blythe had made this comment as well, we're doing this with the best of intentions, listening to patients who don't have access to durable healthcare. Let's try it. Let's see. Will an AI-assisted chatbot actually solve that problem? If not, we'll pivot. But I do think we're overestimating. I'll say this being self-critical of what we're building at a place like Amazon, that trying to triage 80% of somebody's medical complaint or side effects from, say, a GLP with a multi-turn AI experience probably is going to cause annoyance more often than it's going to cause satisfaction.
I think there's a point to make about how many bites at the apple you get when it comes to people's trust. And this isn't just with the public, this is also inside the medical community. So there was a time when we're desperate for treatments for Parkinson's disease. People were extremely gung-ho a decade ago about fetal tissue transplants. There was a big fetal tissue transplant trial that then had worse side effects than there's a lot of enthusiasm for it, worse side effects than people had anticipated. The whole field ran away from fetal tissue. They ran away to GDNF and other things that didn't work and cycled back a decade later, like maybe we should revisit fetal tissue. And there's a real question about whether the urge to move fast in that domain scared away and delayed innovation because people were afraid of a whole platform. And so I worry about, Google's summaries tell you to put glue on your pizza if you want the cheese not to fall off, right? And it's like, okay, so that's a thing everybody knows enough to be like, that's not right. And so when it's giving you a healthcare summary, I wonder what's the glue on your pizza analog, and how often can people tolerate that? Because what my worry is 5 years from now, we're not going to be using, the same generative architectures. We're going to have new architectures that are going to not work the same way, but they're also going to confabulate a lot less. And so now we're going to be like, hey, our models are really good now. And the public's going to be like, yeah, I already had glue on my pizza, right? And so I just don't know how many bites at the apple, we're going to get. People are already reluctant to use analytic tools. Forget about AI, right? There are a lot of tools that have been validated to be better than the average diagnostician. They're simple algorithms. People don't want to use them because they all think they're better than average. And so like getting people to actually use things is itself, a
And when you
problem.
say people there, you mean physicians?
I mean clinicians,
Yeah.
yes. Mhm.
Okay.
I was going to offer a slightly different perspective on this. I understand and agree with all of those arguments, but I think that this is one of those areas that suffers from a lack of an ability to examine the counterfactual in a sophisticated way. So the example I was given earlier by your doctor friend about this scenario now where patients are arriving with a differential diagnosis that's being generated, it would actually be interesting to look at that systematically and say, well, how often was that superior to the differential that specific clinician might have generated? And how often does the doctor actually maybe talk the patient out of what actually might be their diagnosis? I think being able to reflect with a degree of accuracy on how we perform as clinicians is really important grounding down. And this is sort of what I was referring to in an earlier comment, because I think that sort of determines the performance thresholds. And I don't want to go back to an earlier example and suggest that I'm endorsing a self-driving car, but this is the difference between a floor and a ceiling. So
Right.
if you look at Tesla, will say that their data suggests that their cars have an accident once every 4 million miles, and that compares with human drivers that have accidents once every 137,000 miles. And so if that's the difference, then no one could argue that their self-driving system outperforms an excellent human driver. But it's also hard to argue that it doesn't potentially outperform very bad drivers.
So that sort of points in two different directions, right? There's the compared to what question. So if we think that the world as it is highly inequitable in terms of all kinds of racial and gender and bias and economic inequality, does AI make it worse? Does it make it better? Is it just totally orthogonal to that the issue is those inequities and the technology doesn't change them, right? The problem remains the inequities and the technologies, so compared to what, right? So that's one question. The other question is, if we know this about human beings, that they're less trusting of machines, and so that if the machine makes a mistake, we are going to hold it against that technology more than we would against humans, right, as a species who make mistakes. Does that argue in favor of regulatory approaches that are more protective so that the technology will be adopted because we think the technology actually improves things or could improve things? And if we allow it to roll out, if we allow Tesla to just send out full self-driving and call it full self-driving before it's ready, people will reject the technology for decades.
They are already very cautionary. Do you know how many years it took to approve, right? If you go to Seattle Airport, you can now get on these trains and they don't have a driver anymore.
Yeah.
This took like decades of validation under these highly controlled circumstances. I think we are already incredible, and if you look at the FDA as another example, incredible cautionary at the risk of losing many of the benefits and untold lives of people that haven't been seen in terms of counterfactuals.
I think this is a great conversation to have, and I would love to see the firms that are putting out systems, what their thinking has been about exactly this, like how many false positives are you willing to tolerate? Look, there are drugs that, they're effective for your condition, but we know actuarially that there are going to be people who take them and have very severe side effects and they're going to die. And that's sort of ineliminable. So it's not perfect. Like, you never go for perfection. But like an interesting thing would be like, have you thought about how many errors like this you can tolerate? Like, when I think about the business stance from Air Canada, Like their response should have been like, yeah, this thing's not going to be perfect. It's going to make mistakes X number of times. We should be prepared for that. And then we should backstop it so that it's like, yep, if it makes a mistake and, like it told you this, fine, we'll cover it, right? Like that's how much we believe in our system. If you don't believe in your system that much and you're going to offload the risk onto other people, this is a human decision, by the way, this isn't AI, then it's like, whoa, now we're in a really toxic ecosystem where we're offloading the risk onto other people. The last thing I want to say is, with self-driving cars, just keep in mind that the denominator for human driving is 3 trillion miles a year in the United States alone. So when you put the 30,000 people who die every year, put that over that denominator, and then put the number of people who've been killed by autonomous vehicles over the much smaller million miles over multiple years, and I'd still prefer to be driven by a human.
Can I just later on just to build on the clinical argument, we're now saying, let's take the contactless biometric scan for high blood pressure as an example, something we talked about earlier. Right now, is that gonna yield false positives? It's absolutely gonna yield some false positives, but it's gonna probably save people's lives in places like Switzerland, elsewhere that have adopted it. I'm a firm believer it's going to, because it's solving an obvious problem. What are we doing? Instead, so it's gonna cause false positives. We're gonna have something to blame, and that thing to blame is this new diagnostic that's AI enabled, that people can train their criticism and their anger towards. Oh gosh, that caused some false positives, some more avoidable ER visits. What do we do now? Right now we say, well gosh, we have imperfect tools, and oh, by the way, it's on the patient. They should utilize those tools. They have agency to utilize the tools. They have agency to live a better life, to exercise, to do all the many things to prevent high blood pressure in the first place. And if they're not doing it, it's their fault. And so the difference here is who we are blaming right now. We are effectively blaming the patient when we have delayed diagnosis because we give them imperfect tools to understand earlier that, oh, by the way, you might have something that needs treatment. We're blaming the patient. Even if we're not saying we're blaming the patient, we're blaming the patient. Now we introduce these tools that are imperfect, but are pretty darn good, and we can give them insights they don't have today. So there is that trade-off. Who are we gonna blame? I think we're gonna start to blame AI and machine learning and all these tools that we're gonna embed because we have something to blame. Now what we're now doing today in our current architecture is we're by default blaming the patient for not taking agency of their own healthcare. And I think that's the tension here. Who are we willing to blame and hold accountable to? And that's where I would say we have to be willing to accept some trade-off. And I'm not willing, I'm curious what the other clinicians on this panel think, I'm not willing to see a 2049 reality that looks like 2019.
Yeah, I would agree with that perspective. And maybe to underline that point, getting back to this sort of relational potential threshold, we actually know that patients keep going to see doctors that are not good doctors, but are amazing human beings. If you have a good relationship with your doctor and you perceive them to be a great human being, you will keep going back to see them, even if they make mistakes in judgments about your healthcare.
Do we have a test for that, great human being?
So, how can, this is another audience question, how can AI help with healthcare prevention, sort of wellness promotion versus treatment of disease?
That's a really great question because the social determinants of health play a huge role in determining who's likely to get sick, who's not. And those things are very, very patterned in our society. So we know who lives closest to plants that emit particulates and who live close to sites that are polluted. The United States spends more money than any other developed nation on healthcare. 50% of every dollar spent around the globe globally is spent by an American on healthcare. And our healthcare outcomes are worse than any other economically developed country. And so, these investments in healthcare, it's super important to have innovation in healthcare, but we also have to start thinking about what are the ways we can restructure our society to make people healthier and have healthier environments. And so one question that I would have is about the degree to which the phenomena that you're seeing is a failure of diagnostics, and how much of it is a failure of the ability of people to have a clinical care provider, to seek healthcare in a timely way, to afford the medications that they would need in order to manage their healthcare along the way, because I think those are known and important pathways that the Affordable Care Act has made important strides in trying to close that gap, but there's still a fairly significant gap. And I'm not sure about what the role for AI in that is, as opposed to just like social change and trying to be a more compassionate country.
Yeah.
I have a Microsoft-specific question, Stephanie. The question is, how does Microsoft Responsible AI Framework apply to its investments in OpenAI, and what is Microsoft doing to encourage industry-wide self-regulation? So do you use the investment in other companies as ways to propagate Microsoft's approach, or is there a connection between those?
I'm not really privy to the information about our relationship with OpenAI and how we review the models. I mean, obviously, I'm sure our standard is applied, but they have their own approach as well, and so I can't. I mean, that's just not in my realm of where I work in Microsoft. So I mean, I do think that we think our framework is good, and that's why we've worked with NIST and other associations to kind of advocate for something like that. Not that we have all the answers, but I think we would love to see that improved upon if in any way that it needs to be as the technology evolves.
Well, so this is a follow-up on that, and it's another audience question, but sort of related, which you alluded to a little bit in your response, and I'll open this up to everyone else. But what kinds of partnerships would be helpful to propagate responsible use of AI? Like what industry, government, or intra-industry organizations, or consumer protection groups? Like what kinds of partnerships are most needed to ensure the responsible use of AI in healthcare, especially?
That's a good question. Like I mentioned, I think our company, there's a lot of people across the company that are working in responsible AI, but also working in healthcare. We just recently actually kind of stood up this council that I'm part of as well, of just people across the company coming together and talking about what are the relationships that we have, the organizations that we're talking to, studies that we become aware of, just really trying to share information and see, where we can learn more, where we can build more bridges in communication. Because as I said with my remarks about our relationship with within the ecosystem, I think we're trying to do as much outreach as we can. So I'm not sure what we're missing. But yeah, sorry, I don't know. Do you have any thoughts from like an Amazon perspective? I don't know I'm here talking about Microsoft Responsible AI, but I don't know what we're missing, I guess, right now. I think we're trying, maybe again, we talked about the patient, right? Like patient advocacy, that was a question I got recently from a general counsel, actually, of a healthcare company, just saying, like, what is Microsoft doing in terms of outreach to patient advocacy groups? So I think that's really important and something I'm taking back to the company, too.
Yeah, I'll add, just from my experience of applying AI models in healthcare in different countries, that local laws and regulations have different expectations for patient engagement. So, for example, for what we do in the US, to do the same thing in the UK, we had to bring in many patient advisory boards to be able to, for the government to feel confident that the population of the UK felt comfortable with how their personal health data was going to be used, and to get buy-in from the patient community that this was going to be net positive for the community to be able to benefit from it. So it is interesting to see how powerful government policy is in changing the way businesses work. Because in Japan and Germany, similarly, the expectations and requirements for patient involvement or patient consent, it's unique in each healthcare
I
setting.
wish we could do more learning on that topic, actually. Like, that would be a good topic for a conference or at least a panel. Yeah, that's really interesting.
In finance, there's a regulation. It's not a law, but there's a regulation that basically says the CEO and the board of directors are responsible for model risk. And so there's a real debate going on now about like how much of AI should fall under model risk in the finance world. But I think we need an analog to that more broadly in the corporate world, because I think it's possible for a corporation to stand up internally a responsible AI group that would produce a bunch of documents that then don't actually affect the behavior of the firm. And so were there statutes that then said, look, if you put out a product and there was a problem, that like it's the CEO and the board of directors who are ultimately responsible for that, that might have some traction then in making sure that more local policies for responsible AI actually affect the behavior, of the firm. Enron, for instance, had a really wonderful business ethics document. It was discovered during discovery. FBI discovered it, and it was super great, right? It never affected the behavior of the company.
And to build on partnerships, I haven't seen it, and maybe some of you have, but I don't feel like legacy media knows how to cover and talk about and profile stories of success and failure in artificial intelligence, just broadly. And it reminds me, it's evocative of our elected officials. I think Christof had mentioned this. Really, nobody has a vocabulary to talk about this intelligently at Capitol Hill, much less in state houses. But then our legacy media, which people still tune into and that informs and is syndicated in social, also doesn't really know what to cover and how to talk about this. And so when you're thinking about who is controlling information flows and what's being regulated and where clicks are going, the media and our elected officials are two powerful stakeholders there, and I don't think either one really knows how to what to profile, how to do it responsibly, what are feel-good stories that help tell good intent, because I do believe that in most cases there's good intent, especially in healthcare AI. So obviously there's some bad actors, but if we don't know how to cover it, and if we don't know how to legislate it, and then those people are still soaking up the airwaves, that is a problem.
Joanna?
Just make one point, which is I completely agree with that. I think it is really helpful for the private sector. And I think Microsoft's obviously doing a great job here to educate the people, in the media and public officials. I mean, it takes a little bit of time, but you open up those conversations and allow those conversations to happen because, you notice it when, we all notice it when media covers a story we actually know a lot about. We don't notice it with the things that we don't know. I just assume all those things seem true. So it's obviously not the case. I remember when the SVB Bank, Silicon Valley Bank debacle happened, we were behind the scenes with a lot of information on that, and I think it was the first time I realized that even the New York Times podcast wasn't that, like the Daily wasn't that accurate, and it really was disturbing to me because it was kind of probably one story that I actually knew so much about, and I realized this is actually the case for everything. So I think that we do have to sort of educate each other. The people who know can't just sort of sit and say, I can't believe the media doesn't get this right. Well, help get that right.
But look, the media is biased as any of us, whether
of course, yes.
psychedelics, politics.
Do people still consume the legacy media? It's an honest question. I was talking to my son, and he's telling me about some guy I'd never heard of at all, right? And he's like a YouTuber who has 1 million plus people who watch him all the time. And, I think the networks are happy if they get a couple 100,000 people tuning in. And so, I do wonder about, I'm assuming there's not like a news YouTubers, right? But I do think in terms of thinking about the way we diversify how information is really sort of distributed, and that there are examples on social media of I think in the disability community has done a good job of sort of having people's voices get heard about like what are the things that we use, don't use, where can we have an impact, and so I think democratizing those kinds of voices is a more hopeful because I think people will tune in longer. You can get longer form.
Joe Rogan.
Joe Rogan.
Yeah, right. Okay, QED.
Christof, the audience question for you. What is your view on free will? In 2 minutes.
Whoa, it just happened again. Every time I will my right hand to rise, it actually rises. Yeah, so we have free will. Computers don't, humans have free will. Not in all decisions, if you fall and, abruptly, move out your hand to protect you from falling, that's a reflex. They are unconscious behaviors. We know that. We can study that in the lab. But when you clearly delineate, when you think about a fork in the road up ahead, you either do A or you do non-A, you B, you marry this person or move to that job, that is a freely willed decision. It's not emergent, it's not compatibilist, it's the classical libertarian notion, but it depends on your metaphysics and the metaphysics you hold. If you're classical physicalist, then of course there is no free will. It's all either random, as in quantum noise, amplified, or it's all predetermined.
But where is the line between when the circumstance or the context sort of intersects with your free will, like you think it's free will, but it's actually not?
Well, you have to clearly think about the decision. So there's you come to a fork in the road, right? And there's decision A and there's decision B, and you think about it to the best of your ability, which of course you're always biased, right? Making a free decision does not mean it's unbiased. In fact, you wouldn't want it to be unbiased because then it's totally random, and we believe we make decisions. These are not random, but they're meaningful. They're compatible with our sense of ethics and history and autobiographical self. So yes, there's always bias, but the question is it predetermined by something else, or is it my freely willed decision? That's what people care about. Right? And in fact, we assign responsibility, we punish people, we praise people. All of that only makes sense on the background that you could have done otherwise. She could have done this, but she did that. He did this, but he could have done that. So the counterfactual is only relevant if you're able to take that decision freely. But that's why we don't punish people when they're drunk, or we don't, animals typically, we don't think of free will because they don't have this clear conscious deliberation, or little children, right? Typically, you need to be 18 or older in order to be fully prosecuted by the full extent of the law, because of your brain and your mind is not yet capable of thinking about these possibilities, these two forks, and why you should choose one versus the other.
Thank you.
Classic.
Glad we cleared that up. Okay, last question. This idea came up earlier in the smaller panel about being human-centered as a sort of baseline for an ethical approach to AI. Maybe building on this discussion of free will, let's look forward into the future as far as, let's say 20 years, as this technology changes. Is that going to continue to be the standard? Should that just be a fixed point for us, that as this technology becomes more capable, as these models become more human-seeming in their interactions with us, maintaining a focus on physical embodied human beings as the sort of center of our ethical universe, is that the fixed point we need to hold on to?
I would say yes. I think if we don't, we lose our way.
Yes.
So no Android rights in the future, Christof?
Well, I mean, the future, Blade Runner, et cetera, but at least the futures I can see ahead over the next 20 or 30 years, yes, I don't see any of that happening. It has to be human-centered. It can't be centered on anything else. It has to be relevant to us because we're building it for us. Hopefully, for us.
In drug development, we've at least tried to change the incentives that drug companies face to develop drugs for populations that aren't going to be as lucrative. So we'll extend your patent on something that's really lucrative if you'll develop a drug for a population that's it's a smaller population, whatever. Those things have their problems. I'm not saying that's a panacea, but like this is an effort where policymakers are trying to use the levers that we can to incentivize people to do development efforts in a place where they wouldn't, but that are more inclusive. We need something like that in the tech AI space. We need something, because there are a lot of AI that could do good, but it's not easy to commodify it, and so no one's gonna make a lot of money on it, and so it's orphaned. And so we need the ability to fund people to do those sorts of things. And then the other thing is, so we've talked about privacy and private data, and would you make your data available? We don't live in a world now, if you made your data available, you're not giving it to the commons. You're giving it to somebody who's gonna wrap it in a proprietary package and they're gonna sell it. We socialize data. So even people who have copyright over all their stuff, we have technology companies that are hoovering it up over the internet. They wanna socialize the data, then they wanna privatize the product. And so if the bargain was, I make my data available and it's open science, what you do with it, everybody else can see, everybody else can leverage, and that will be in the public domain, and you compete on efficacy, I would do it in a heartbeat. If it's giving it out now, where it's like you can wrap it in your proprietary wrapper and make money off of it and then not let other people see what you're doing, I'll keep it.
I'm just going to have an opportunity, anyone to make any point that you haven't had a chance to make today before we wrap up. It's not a question, it's just an opportunity. If not, I will.
So there is, we talked earlier a little bit about prevention, right? So there is, I attended we have an annual symposium where we had this topic, you know what I mean? So for example, if there is an AI model which is doing a prevention algorithm for a patient, and the null hypothesis for that model would be, let it not miss any dire situation with the patient, because patient is believing the model to tell when to see the doctor, okay? Because of that null hypothesis, it will generate false positives. And this false positive, I think Vin talked about, is it's going to increase the healthcare costs, okay? On the other hand, when you have an AI model with the clinician, you know what I mean? The clinician then cause no harm, okay? So these are at odds at each other. So it's an interesting thing is that if we look at, in the end, anybody who's developing a model, they are exactly looking at what is the best way to protect themselves. Okay, so for example, a doctor, if he's using a model, I don't know how the malpractice, the whole insurance works through that. Even for an AI model producer, there needs to be a mechanism, you know, for that. You know what I mean? So, because when you ask a statistician, they will tell you, what do you want me to the results to show? Because you can tune your sensitivity to false positives and true negatives in any way you want, and you can bend your accuracy curve, okay? So there is a human responsibility there. Whoever is producing the model, okay, there is a human responsibility there. That's where the ethics governance should be there, because the person who's making that call, okay, that's where the governance has to be there. And once that governance is established as a framework, then this innovation can thrive. Because otherwise what happens is, if you govern too much of the output, then the innovation is going to stifle. That's my technology view.
Steph.
Can I just say something really quickly? Sorry, it's
Yes.
Just because you said final remarks of something we didn't get a chance to say.
Yep.
I just wanted to respond to the question that was asked earlier about how Microsoft deals with OpenAI models, because I think I didn't give a good answer there. I mean, I don't have, like I said, I'm not privy to what the contract between the two companies says, but when we take models from OpenAI and we release them as Microsoft products, Azure OpenAI service, you know, within Bing or wherever, obviously that all goes through our process and our responsible AI process and our testing process. But as I understand it, there are some things about those models, how they're trained, that we maybe don't know, and that might be in the contract, and that I'm not aware of. But yeah, to the best of our ability in terms of the adversarial testing that we do, red teaming, extensive red teaming, it meets our bar before we release it as a product. So I just wanted to clarify the record on that one.
Thanks. Anybody else?
I feel like we're gonna end this discussion on false positives, but so hopefully not. I was just gonna come back and quickly say, this is ethics in tech, and we're talking about the ethics maybe of having false positives, increasing healthcare costs. But then it goes back to the predicate. What are we comparing it against, which is the current state, which is fundamentally unethical, which is 90% of people, again, with chronic disease don't know they have a condition until it's too late. That's not ethical. And so am I, as a clinician, willing to tolerate a 10%, 15% false positive rate, which means inconvenience? Yes. But that's the balance that we have to weigh. What is more unethical? And we have to think about the predicate and what we're comparing it against, because I worry that we're going to aim for perfection in the development of these tools when the predicate is not, oh gosh, is it 10% or is it 1% false positive? No, it's the current standard of care in medicine that we should be comparing these tools against, which is fundamentally unethical.
Well, I'm going to make sure we end on a true positive, which is that this has been really interesting for me as a non-technologist and non-healthcare person. So I just want to thank you for your participation today. I want to thank the audience for great questions. It's been a really interesting discussion. I've learned a lot. So thank you all for being here, and enjoy the rest of your evening.